when I was talking about topics with Ted a couple of weeks ago, he suggested I, again, share more about the symptom data we had. So let's see, Tina, can you see my slides? Okay, great. So the first thing I wanted to do is, again, I know people have seen this before, and I know the limitations, or some of the limitations of our risk tool, but just to reemphasize that we are still using this to make decisions about who we follow in VOMC and to what extent. So originally, VOMC followed all patients with regular telephone calls after they got a positive PCR and were told to isolate at home. A few weeks ago, when the APPs that were redeployed and taking care of these patients, and so these were folks from surgical clinics, radiation oncology, lots of sources, when they went back to their homes, the VOMC team got a lot smaller. And so we started to look at data for this tier 1 patient group and realized that they were very low risk compared to the other tiers. So because of that and the limited staffing, the VOMC stopped following tier 1 patients once they had been designated tier 1. And they just, for the last few weeks, have been giving them advice to call the COVID hotline or to call their PCPs if they had symptoms. But before taking this step, they did have a full telemedicine visit with a VOMC provider, somebody who was doing COVID visits all that session to kind of give them this tier 1 designation. So this wasn't something that was just slapped on. It was really after a review of what was going on with the patient, usually on symptom day 9, 10, something in that range. So a lot of data was available at that time. So the tier 1 patient was defined as age less than 60 and no clinical risk factors for severe COVID, with mild symptoms at the time of evaluation. And their symptom course had to have been stable or improving. And then they had to be in a situation where they could self-isolate, and they weren't giving you the phone call or doing the visit from their car or saying that they had to leave their home or something like that. There were a number of patients who were assigned to tier 1 because there was a big asterisk on this that said if you were seeing them 20 days into illness and they were 70 years old with heart failure, but they were feeling much, much better, you could also put them in tier 1. And just follow them for that 7 days. We said we were going to follow these folks for about 7 days after intake. So it gets more complicated, and I can't quite see my full screen, but yeah. So for tier 2, it's where it really starts to get complicated, and maybe to some extent unnecessary, because I'll show you the data for tier 2 and tier 3 admissions. But for tier 2, we said, okay, once you're over age 60, you can't be tier 1 if you're in the first week of illness. We just know that hospitalization and severe illness is much more common. If you're a younger patient, but you have a risk factor, and I'll show you the list, but it was the things that we knew were putting people at risk, like by early April, we knew that obesity, diabetes, hypertension, any form of chronic lung disease would put people at higher risk for severe illness. And that's the main distinction between tier 1 and tier 2, was just the age or the comorbidity. So I apologize, I know it's complicated, but you don't really have to memorize tier 2 per se. Tier 3, here's a list of the risk factors. So kind of the tier 2 risk factors, again, this could be updated. Things are changing. There's a lot of information out there, but this is what we were using for the first couple of months. So just to give you, the yellow here is tier 2 risk factors. And then the red was tier 3 risk factors. And one could argue that immunocompromised may not actually be, you could do a lot of manipulation here, but this is where it's been for us in terms of risk factors. So tier 3, if you had multiple of the moderate risk factors, particularly if you were in your 60s, that's what would qualify somebody for tier 3. And you see, it looks really messy when I try to put it all together. So you're either over 70 and healthy, and there is data, I know Ted particularly is interested in, about sort of, not everybody who's 70 is the same, but we were working with very sort of raw information here. If you were under age 70 but had one of those red high risk factors, and then if you were in your 60s and had multiple risk factors, if you were in your 50s and had the metabolic syndrome, diabetes, hypertension, obesity, that might be high risk as well if you're in the acute phase of illness. And then the clinical impression was really key for tier 3. So you could see somebody who's 50 and healthy, but if they're short of breath walking up a flight of stairs and you see them in arc and their pulse oximetry is 94, and then when they walk it's 92, that would be a tier 3 patient. And so that's kind of how we distinguish these. And we anybody who was going to do these visits, we asked them to do a 1-hour training to know how to assign the tiers, because we recognize, number one, that early on, we didn't have a lot of testing available, so we started to get referrals with tiers for patients who didn't have COVID, but maybe suspected COVID, but turned out to be pyelonephritis. So we limited this to patients with confirmed COVID, with providers who were doing it on a regular basis. And we recognize that the post-discharge team, the hospital discharge team, uses the same tier criteria, which gets a little confusing, 1, 2, and 3 with some of the same criteria, but then they overlay, the severity of the hospital course. So the terminology gets mixed up. But this is what we were doing for outpatients. And so this is useful in the current surge because we were seeing a lot of tier 1 type patients, and we still haven't looked at the data. So that's going to be a really important next step to see what's happening with this July group of patients. But here's for, and this was created by David Tong in hospital medicine, looking at our data for the first 500 patients in March, April, and into May. And so what you'll see is 2 things. Number one, he had to break out the data into male and female because there was a time interaction. So males get hospitalized quicker in our outpatient group and at a higher rate. So beyond that, sort of the key thing to know is that the tier 1 patients were hospitalized at a pretty low rate, which is what we were hoping for. And this did seem to confirm that. The tier 2 and tier 3, they are hospitalized, particularly male tier 2, almost 10% hospitalization rate. So they're not low risk in my view, but then tier 3 was sort of a very high rate of hospitalization, very fast in some of those early, but up to, it looks like close to 30% of those patients. So that's kind of the key that I wanted to highlight, is there's a reason we're saying, tier 1 patients don't need to be followed as closely. And there is a reason we're saying that tier 3 patients should have somebody checking on them pretty regularly after they're diagnosed up front. So I think VOMC hopefully will be able to staff to at least the tier 3 patient needs for regular scheduled check-ins. And as primary care doctors, we said this originally, but we continue to say this, don't hesitate to layer care. So we can have patients doing the tonic surveys, because those have gone live last week, where they're putting their symptoms into the computer. They can get a call from the VOMC, and they can have their primary care doctor doing a telemedicine visit to actually see what they look like. We found those to be very helpful. In VOMC, the face-to-face sort of aspect of the virtual visit is helpful. And to that point, when we looked at the hazard ratios for the tier assignments, we couldn't recreate a tier 3 just with clinical factors. So tier 3, the adjusted odds ratio for hospitalization was 15, even when we controlled for all other factors. And so I guess the point of saying that is that there is something about a skilled provider doing the visit that we can't create just with check boxes. It's not just older patient with these comorbidities with mild, moderate, or severe symptoms. It's also the provider putting it all together, thinking about where the patient is in their illness, things maybe about their functional capacity, where at the end of it, they say, this is a tier 3 patient, this is a tier 2 patient. And so I think it is useful for primary care doctors to start to maybe not use this tier model if it doesn't work for you, but to think about your patients in terms of these kinds of risk factors and where they are in their illness when they're being diagnosed and seen. So I wanted to present this data to you. It hasn't been peer reviewed, but you get the idea. Now, interestingly, even when you control for tier, 3 risk factors came out as still significant, and these are in the tier, at least the age and obesity are in the tier. So we find that age is still significant even after you look within tiers, and so is obesity, and so is male sex. The obesity is interesting. When we looked at actual BMI in EMER versus obesity coded in our notes, there were 60 of the patients who have BMI over 30 at their last office visit that was missed at the VOMC intake. They didn't report obesity. And that's consistent in previous research, I guess, so underreporting of obesity. And it does seem to be such an important risk factor here that it's probably worth looking at the BMI of your patient before you put them in tier 1 if they're in the acute phase of illness. So that's a comment about that. So we're looking at maybe even creating a list where if patients meet criteria, they don't need a VOMC 40-minute intake visit. And we modeled this looking at our original patient data. And so this was saying, okay, what if the patient, regardless of everything else, can these be true just check boxes? Age under 60, no comorbidities, not BMI over 30, symptoms are mild, and they're able to isolate. And so forget, if they're in their second week, this, if they're in their first week, that, if they just meet all these criteria. And we found that identified all 35 hospitalizations out of the first 500 patients. And so you would have a small group, I mean, not insignificant, 114 of those patients, you check all those boxes and none of them were hospitalized. So that's something that we're looking at. For people who are interested in race and ethnicity, I think we all are, and the impact, we didn't have power to detect a significance in this study. So there is a really interesting preprint that's relevant to us because it's Atlanta geography based. And I know there's other folks with their finger on this dashboard, but they have maps in their preprint that show certain neighborhoods in Atlanta where there's a higher risk of COVID and severe COVID. But their conclusions were that there weren't significant differences in clinical outcomes. So it seems to be sort of multifactorial in terms of the impact of race on illness severity. And I'm just acknowledging we don't have good data from our VOMC cohort to present on that. So I'd reference this and folks can go take a look at that. I wanted to get to symptoms in my last couple of minutes because if VOMC is stepping back from patients who are low risk for hospitalization, it may be incumbent on primary care doctors to do more symptom management because that's one of the key functions. So this is not tier one, this group of patients in this particular heat map I'm showing you. This is actually what Dr. Tong, David Tong found when he looked at it was that the symptom severity was the biggest predictor of the symptom course. So this is patients with mild symptom severity, and then the next slide is moderate symptom severity. Most patients with severe symptoms, which we defined as sort of severe lower respiratory or severe systemic symptoms, we referred to the hospital. Just by our definitions. But so mild patients, you see that smaller numbers of them will have the GI manifestations, but cough management is probably the main area of focus here. And I had presented data in previous talks about things that providers were reporting were efficacious. We don't have patient report data yet, but providers are saying things like OTC cough medications. Honey at night, our nurses who do the follow-up calls say that 10 grams of honey is helpful to the patients when they recommended that. We included it because it was on the UK guidelines. And then albuterol, which I was sort of skeptical about at first, but last week, we had a talk about persistent COVID symptoms and the airway hyperreactivity or inflammation. And so albuterol is also effective for some patients. Here, just to show you the difference, if you have a patient with moderate severity, you are going to see a lot more systemic symptoms that you're going to be managing, even into, so say you're meeting the patient in the 9th day of illness. This is where you see more, when we define moderate severity, we're looking at more shortness of breath with exertion. And so this is an area where we have more touch with the patient to make sure that that's not progressing, to make sure that they're not hypoxic, which is the most common reason for hospital referral. So I showed this data and I'm willing to sort of field questions about it. It's not peer reviewed. We're hoping to, obviously we're trying to format it to move that direction. We had very few patients with high severity symptoms. So this is what a heat map looked like. There are only 4 patients in that group. So I'm not gonna dwell on that. Persistent symptom data, looks like I've got less than a minute left. So just to say there's one paper in JAMA for people who are interested. This is in Italy, a post-hospital discharge clinic, seeing patients about 2 months after hospitalization. There are a lot of persistent symptoms and they do correlate with the symptoms the patient had during illness. We have similar data in our cohort. The blue bars are when we called 2 months after mild COVID. The symptoms that the patients reported were still present, even mild. They were mild, but they were still there. And you see that it does correlate with the orange bar, or it appears to correlate with the orange bar, which is the symptoms that were present at their last VOMC call, which was usually about a month before. So this is a very slow to resolve illness for a lot of our patients. And so that's all I wanted to say, that just being engaged and involved with these patients during their recovery, I know that everybody already is, but wanted to emphasize that point. And I'll end there.